Good morning, everyone. Welcome to day 2 of the EIT Health Summit. How are you all this morning? If you're feeling well, put your hands up. Great. Thank you so much for being here nice and early. We've got a really fantastic day lined up with more really excellent expert speakers and breakout sessions. So, and also a warm welcome to you watching online. We're hoping that you're getting a lot out of it just watching the discussions and taking part in the Slido questions. So today we have lots more lined up for you. We're going to hear 2 inspiring stories about digital innovation that is transforming and improving lives in an inclusive way. So we're going to be joined shortly live online by Audrey Tang, who is the Digital Minister of Taiwan, and then you'll have a chance for a Q&A with her through Slido as previously. So get your Slido out and do start posting them as you think of your questions. So Minister Tang, first of all, recorded this video for us.
Good local time. I'm Audrey Tang, Taiwan's Digital Minister. I'm really happy to be here virtually to share with you some thoughts around digital social innovation. Social innovation, or everyone's business with everyone's help, enabled us through a collective intelligence to counter the pandemic with no lockdown and counter the infodemic with no takedowns. In Taiwan, we have this forum called the PTT. Here we see that the PTT countered the pandemic by sounding off advanced warnings when in 2019 December, Dr. Li Wenliang's message from Wuhan that said, and I quote, "There's 7 new SARS cases in the Huanan seafood market," gets triaged on the forum. The very next day, the first day of 2020, we started health inspections for all flight passengers coming in from Wuhan to Taiwan. Thanks to this public digital forum with no shareholders or advertisers, subsidized by Taiwan Academic Network fundings for the past 25 years. And so this enables us to listen at scale. Of course, not everyone is familiar with digital forums, bulletin board systems. So in Taiwan, anyone can pick up the phone and call this toll-free number 1922 to contribute to collective intelligence. For example, last April, there was a young boy that called saying, "Hey, you're rationing on masks, but all I got was pink ones. All the boys in my class have pink masks. Why don't you do something about it?" Well, in our everyday 2 p.m. press conference, the very next day, all the medical officers were pink. And Minister Chen of Health and Welfare even said that Pink Panther was his childhood hero. And so the boy became the most hip boy in his class overnight, for only he has the color that the hero wears and the hero's hero wear. And through Creative Commons, all those mimetic pictures that pertains to collective intelligence get spread very quickly on the public web so that people can access the science and clarifications faster than they would conspiracy theories or rumors. It also enables a fair provision of resources without compromising human rights or privacy. In particular, when we made the mask rationing last February, there were more than 100 different tools co-developed with communities such as G0V or GovZero that look at all the government digital services that ends in something, the GOV, the TW, changing an O to a 0, build a kind of shadow government, fork the government into a different direction so that people can access the same information but with a much more friendly and accessible open access. So this picture you see shows the map that every pharmacy in Taiwan lists the real-time pharmacy stock of medical-grade masks. So people don't have to queue in vain in line, but rather they can navigate very quickly to the nearby pharmacy that still have the mask in stock. And we maximally trust the citizens with real-time open data updated every 30 seconds. And that enabled the entire society to co-develop better distribution mechanisms, pre-ordering, and so on. And those civic technologies in this May also co-created a contact tracing system so that when entering each and every venue, people can scan very quickly the QR code without unlocking the phone even, and send an SMS, and that's it, like literally just 3 seconds. And each and everyone can trust their telecom providers to never share this information with the government or multinational companies. These are stored within the telecom carriers for just 28 days. So out of around 250 million SMS sent automatically this way, only around 1 million gets audited by the contact tracers so that they can very quickly find the exposure contacts and reduce what used to take more than 24 hours in contact tracing, interviews and so on, automating it to less than 24 minutes. In addition to the fast and the fair, the fun, the memes, humor over rumor are also very important. For example, earlier in the conversation around physical distancing and mask use, there's a lot of different rumors, misinformation spread on the net. But because of this very cute spokesdog, the Zongchai, is a Shiba Inu, an official spokesdog for the Central Epidemic Command Center. So we see a lot of meme pictures, such as the one on the top left that says, when you're indoor, keep 3 Shiba Inus length away from one another. When you're outdoor, keep 2. Or on the bottom right, wear a mask to protect your own face against your own unwashed hands. And because this has a higher basic reproduction rate, a higher R value than disinformation and conspiracy theories, it means that people have access to the scientific details in a fun manner that makes people vaccinated against the disinformation crisis. And we apply this not just to counter epidemic material, but also for digital assets, such as this model of our presidential office, the entire dictionary of Taiwan's national languages, also Creative Commons license, and even my own photo are often remixed to make hip-hop songs or internet memes. Now, of course, it is not just about cultural products. It's not just about the output, the what of the policies. It's also about the why and the how of policy making. Ever since I became the digital minister in 2016, each and every lobbyist visit, journalist visit, and so on, and even most of the internal meetings that I chair, are published into the commons free of copyright so that people can see. I've talked with around 6,500 people in around 1,600 sections and meetings and more than 300,000 paragraphs of speech. And this enables this co-creation of policies because people can very simply drop by my office, which is the Social Innovation Lab, as you can see here, and book 1 hour of my time to talk on the record on how to improve the policies that we're still in the making. And because it's on the record, so people always lobby for the benefit of all humankind and even our next generations, simply because it will look pretty bad if they lobby for something that's only good for themselves at the expense of other people or future generations. It also enabled us to use assistive intelligence, or AI, to power such listening at scale conversations. This tool, Polis, enables us to visualize the feelings, the reflections of our friends and families, our social media friends, around public topics without going to polarization or flame wars or whatever. We first deployed this in 2015 when talking about the UberX phenomena. Even though people differ on whether to call it a gig economy, a sharing economy, a platform economy, people do agree on the facts, the real-time open data. So we use this tool to listen at scale on people's feelings only. This step, often neglected in representative democracy, ensures that only the idea that takes care of people's feelings gets selected into ratification, into the real results of our regulatory co-creation. So this is like playing a pro-social social media game, not the anti-social one. This is pro-social because, for example, when you see some fellows' ideas like the passenger liability insurance is the most important, you can click agree and move toward me, or click disagree and move away from my avatar. And you can also contribute like a wiki, your own ideas and reflections for other people to vote on. But there is no reply button, so there's no room for trolls to grow. And always after 3 weeks of conversation, we see this picture, a true reflection of our democratic plurality. People do disagree on a few things on the right, People can see that there are ideological differences, but people just table them because there's no reply button and concentrated on the ideas that actually most of the neighbors agree with most of each other most of the time. It pertains to, for example, not undercutting existing meters, registration of vehicles, and proper insurance. And so by concentrating on those good enough consensus, we successfully ratified and legalized a new multi-purpose taxi system so that not only Uber is a legal company now in Taiwan, the Q taxi, but it also enables local temples and churches to run its own fleet that serve the marginalized communities. And so this is still KPI, but it is not done in a top-down manner. Rather, this is done in a crowdsourced, collective intelligence manner. And the people who participated in this dialogue simply gets a stronger vaccination against disinformation, biased stereotype speech, because they have considered, taken all the sides, and gradually formed this good enough consensus that unifies the contributions from the business sector, from the social sector, and from the government. So in the style of SDGs, the Sustainable Development Goals, I would say that our contribution in the digital is not to replace any particular human function or human intelligence, but to make sure that we can assist each other in uniting what used to be different perspectives into common ideas. And this, in concrete SDG terms, means 1717, effective partnership, through 1718, reliable data, in the style of 1706, open innovation. In 2016, when I was invited to become the country's first digital minister, the HR department asked me, okay, minister, there's never been a digital minister before, so what are you going to do? What's your job description? I'm like, oh, my job description is just the Sustainable Goals 1717, 1718, and 1706. And the HR people are like, Minister, I don't think the citizens in Taiwan memorize those 169 sustainable goals in their minds. So I translated that into poetry, into a prayer, which is my job description. It goes like this. When we see the Internet of Things, let's make it an Internet of Beings. When we see virtual reality, let's make it a shared reality. When we see machine learning, let's make it collaborative learning. When we see user experience, let's make it about human experience. And whenever we hear that the singularity is near, well, let's always remember the plurality is here. Thank you for listening. Live long and prosper.
Thank you very much, Minister. And we're pleased to have Minister joining us live now here at the EIT Health Summit. Welcome, Minister, and thank you so much for such an interesting presentation, so much to think about there. And I was listening there to the advantages of real-time data, the way you're putting humanity and emotion into your data. But a quick question from me before we get the audience questions. I'm just interested in the truth and the facts. So how do people actually trust the fact that you are putting forward your version of the truth?
What we're doing is we trust the citizens, not asking for the trust back. So the idea is that anyone can report what they are seeing in terms of mask availability, rapid testing availability, vaccination opportunity availability, and so on, using what we call data collaboratives. So the state's role is just to make sure that all the different communities work with each other. So we're working with the people, not necessarily just for the people. And so the data sources come from the civil society, from the community. We just make sure there's a trusted common ledger where those communities can share those data.
So that's, we have a question here which is similar. So how do you actually build trust in the whole digital social innovation? Is it by using ordinary people, building from the ground up?
Yes. So that's an excellent question. So to give no trust is to get no trust. when people see that their measurements, which may differ from the governmental measurements, resulted in the government changing its measurement roles or to correct our data biases and so on in a very rapid way, like literally within 24 hours, it resulted in higher trustworthiness because it's lower latency, it's higher bandwidth, and it connects more people.
So the people that you're using to help you, the citizens that are helping with the various platforms, they're obviously very well informed about digital innovation. What about people who really know nothing about it?
So when, for example, the primary schoolers use a very inexpensive civic tech called Airbox to measure the PM 2.5 pollution level in their balconies, in their schools, and so on, of course, they are the digital natives. They measure it, but because they measure it so that their grandparents, for example, can decide whether they want to go out for a walk, depending on PM 2.5 level, and so on, it improves the digital competence, the media competence for everyone involved. So it's not about us building a service and asking people to adapt to technology. It's about the technology becoming just common primary school education material, the technology adapting to the people so they may find uses within their own families and communities.
Yes, and of course, we start from primary school, but if you think about it, most two-year-olds can almost use an iPad nowadays. It's almost as they're born with a phone in their hand. But I'm thinking about much older people. I saw you had a phone line for them, but are they somehow not included? Do they feel excluded from the digital progress that your country is making?
Not at all. I check all the new services that we design with my grandma, who is around 90 years old. And she is very comfortable with the IC card, the National Health Insurance card, because, well, it's never had a cybersecurity issue since its introduction around 2002. And so she can use that card and present it at a pharmacy, at a kiosk, at a convenience store, or any of the local helpers. And it's those local helpers that helps her to explain the common ledger, the records that she has on the National Health Insurance, and also make sure that all the transactions are kept on the ledger. So if she said, oh, that doctor may make a misdiagnosis, she worries about her data being interpreted in different ways, and so on, any local pharmacist or local clinician may help her using that same IC card.
So we have another question here from Surabai Tak. How were the misconceptions around COVID vaccination handled using digital innovation?
Yeah, initially last April, when I got my first AstraZeneca shot, I cannot convince my grandma or indeed any of my colleagues because at the time, Taiwan literally doesn't have any confirmed cases locally. So they don't feel the urgency and they see a lot of misinformation or disinformation about the side effects of AstraZeneca. And so we simply published the willingness of pre-registration of people getting AZ shots vis-a-vis the Moderna shots, which we did not get at the very beginning, and later on BNT Pfizer shots, and then local homebrew Medigen shots. So by publishing that, so the elderly people did not want to get AstraZeneca, and then every week we publish, so now it's the 50 years old turn, 40 years old turn, 35 years old turn. It not only resulted in AstraZeneca gets into arms as soon as they defreeze, but actually the elderly people learned that it's actually quite safe and their friends and families are getting it. And so it's diverted away the idea of anti-vaccination into the competition, the healthy competition between the four brands of vaccination. At the end of the day, people have strong preferences, but they all get their preferred shots.
Right, and another question that's come in. So does the example of the government, is it being copied by companies in Taiwan? Is the private sector using this kind of format?
Yeah, I call this a people-public-private partnership. So the people sets the norm. The government amplifies the norm. But at the end of the day, it is the convenience stores, the pharmacies, nowadays the insurance companies, and so on, adopting the digital innovations that the social sector has laid out as normal to do, and they scale out these ideas into their own products and services based on the idea of digital self-determination. So we have this My Data platform where people can click and choose the kind of data they want to share, and they can opt out back anytime with the third-party providers. So while the state and government services and the social sector provides the first inspiring cases, at the end of the day, they may translate into better products and services in the private sector.
Minister Tang, thank you so much. How interesting. A round of applause for the Minister.
Thank you. Live long and prosper.
Thank you very much. So we're going to move on to our next inspirational speaker, who is the founder of Epilepsy Sparks and ambassador for Yes I Can with the UK Government Department for Work and Pensions. So I'd like to welcome Tori Robinson. Hi, Tori. I'm going to hand over to you now, but just before I do, I want to remind you, do start posting your questions in Slido, and we'll take them after Tori's presentation. Thanks, Tori.
Thank you very much. And actually, carrying on from that, I welcome any type of question at all. There is nothing too deep and too personal. So thank you again, everybody, for being here. I do like to consider myself a disruptor day to day, but hopefully a positive disruptor. And it would certainly help if I had this in my hand. A bit about myself and my own background. I'm a person with epilepsy. I'm also a person with psychiatric comorbidities. And that'll be why I'm also very passionate about improving the lives of people in the world affected by these conditions or these diseases. I'm also very passionate about empirical evidence. So what can actually be proven? We're all very aware that we see so much rubbish in certain publications, online, offline, and indeed from fellow Homo sapiens around the world. So we have to question things. And that leads me on to education. I always believe that we cannot get enough education. Unfortunately, the more we learn, the more we realize we don't know. But that is a really, really exciting thing. And finally on this page, but certainly not the least important at all, the world deserves health equity. I'm from London in the UK, and it should not be the case that I have better access to high quality care than somebody in a low to middle income country, or indeed somebody from a place that is not a city. And I'm very experienced regarding that, having lived in a more rural area in the past as well. So you'll see here, Epilepsy Sparks Insights. I set this up after I'd had brain surgery for my epilepsy. I had a left temporal lobe resection, so here part of my brain removed because my quality of life and actually my likelihood of dying was very, very high. Through Epilepsy Sparks Insights, my purpose is to educate, to make people excited about epilepsy and comorbidities and research, to bring people realistic hope, and unfortunately, as is required for all of this, as we all very well know, is funding. I'm very lucky to work with key opinion leaders from around the world. So we're talking, yes, on this continent, we're talking from the US, we're talking professors and researchers from Colombia, Australasia, etc. And I find this very exciting too, as do our listeners and our viewers. We know that together, coming together from around the world, we can achieve a lot when it comes to research. And just some statistics. In a pretty short time, this only started last year, we've had over 7,000 downloads, hundreds of hours on YouTube, and we've got over 20,000 followers on different social media platforms, which includes approximately, we would say, 50% clinicians and researchers and 50% patients and families, and a little bit also of the general public who are actually interested in the work that people like you do. So why is medtech important to me personally? And I know to many, many people out there, actually it affects positively the rest of the world. It's just most of them don't know about it. As mentioned, health equity is so important. And it's not just about actually us having as good a quality of life and good a quality of healthcare as we can, but it's about ensuring that all of us have that quality improved so that our quality of life improves. It's not just about the treatment that you might get, it's about what is important for each individual patient and family and societies. Security, one of those big terms, like, oh my goodness, everybody's really scared. There's GDPR, there's what they're going to use my data for. Everyone gets worried about it. Personally, being a devil's advocate day to day, a lot of us, patients and families, were like, do you know what, take my data. I know that I'm not actually that important when it comes to data individually. And if it can help other people in addition to myself, wonderful. Yes, we need to manage the data. Of course we do. And we need to enforce security measures, etc. But we want our profiles to be used to better, yes, our own lives if possible, but also the lives of other people. And I've heard this from patients and families from all continents, bar Antarctica, that is. Our challenges, yes, technology, but I also think that we can, accumulating our knowledge, we can use technology for the better. Lots of people want in-person appointments, I know that. Sometimes it can be good if we don't, because some people might have certain challenges face-to-face. But it has so many benefits, including for lots of people with epilepsy or related illnesses. I get exhausted if I'm up too late. And so therefore, online appointments really help improve my quality of life. Again, data quality can be an issue. Data security, there's lots of repetitions here. But that's because so as well as things being challenges, they can also be, well, how do we deal with that? How can we actually use that challenge to improve the care of patients from around Europe? And preparation. How do we prepare people for the tech that we use? We have, like in this environment here today, we have a lot of people who are generally okay with tech. We think it's pretty cool. But what about those people, many of whom patients have intellectual disability? What about the people who are of an older generation, and I'm generalizing, but may not be familiar with tech? We must not forget these individuals. So the dreaded term funding, this is like what we need to realize, and governments as well as private organizations need to realize, is that long term, and we must think long term, if we invest into the care and research into the epilepsies, psychiatric comorbidities, and generally diseases, we will improve economies around the world. We need to ensure that people have confidence in what we're doing. How do we do that? Through education. That's how we do it. People need to be aware of the security measures that we are using to protect their data. They need to know not just about the risks. We always focus on the negative in the press. They need to know about the positive, potential positive outcomes of what we're doing. We need to improve outreach so that people who might not be watching, YouTube all the time or watching the news channels, how do we get them to take part in this and not just be afraid of everything that's online? We have a responsibility to the rest of the world. We are lucky here to be able to communicate effectively. We are lucky to be able to listen in and be more aware of what's going on behind the scenes in those silos. Lots of people don't, and we need to be able to communicate all the amazing work that is going on to give people that realistic hope and get them on board so that we can all work together. And openness to patients. We shouldn't be hiding things from patients and families just because we might not be quite sure of what the long-term plan is going to be or what the outcome is going to be. As long as we are honest, and as long as we can say to patients and families, do you know what, I'm not really quite sure about the outcome of this, but this is where we are, and this is our plan, and this is how we are taking things forward, and this is how this could seriously benefit you and the whole of society. That's what we want to hear. We need that reassurance. So excitement, all of this together is very exciting for patients, our health, but also our quality of life. I'm excited about improved access to healthcare, about health equity. Imagine we can go out and see a person in another country or another part of the country in which we reside. Do you know what? They're likely to have improved quality healthcare and quality of life because of health equity. Global warming, it's a huge issue for all of us. But if we are doing more care, treatment, appointments, everything online, we are going to reduce our carbon output and reduce the greenhouse effects, basically, climate change. As mentioned, we will, of course, increase GDP. You're going to have more patients and families actually in work, giving tax, and as well as improving healthcare. And that improves the lives of everybody within a nation, within a continent. Thinking long term, this is really important to me, but I think to everybody should we think about it. We're improving the lives of the next generation. It's not just about us. You know what it's like, the older you get, the swifter each day passes by, like with lockdown. Was that like nearly 3 years ago? Oh my goodness, when that started. Just think what it's going to be like for the next generation, for your children and your children's children. Let's improve their lives. And that is the end. That is my last slide. So I very much welcome any questions. Please send those forward. And even if they're even if you think they're naughty and I shouldn't, ask that question.
So yes, do send your questions, and I see you've already started posting them in. Thank you, Tori. Very heartwarming presentation there, and also very honest. And really interesting, because Tori and I were talking before coming on, and the operation that Tori had, I had covered 10 years before that, and it was one of the first ever operations on an epilepsy patient, and it was a part of a clinical trial. So wonderful to see that it worked, and Tori is here many years later, and it seems to be very helpful. But again, you talked about health equity and the fact that you had to move from the rural areas to London to be able to access it.
Indeed.
So here's a question from Laura. What are the biggest barriers in healthcare for you as a patient, and how can innovation break it?
I would say communication between parties is the biggest challenge, both from the perspective of a clinician as well as of a patient. From the patient side, especially if you're unwell, communication can be a real issue. And I'm talking about people such as myself and those with intellectual disability and carers. How do you communicate effectively, especially when you're unwell? And then also, as a clinician, how do you communicate to patients that, do you know what, I can't provide this care right now? Or your life expectancy is limited. I was told that once, and I really appreciated it. Top chap. It made me take things seriously. But we have to be able to be honest with each other. And I think what contributes to our ability to be honest is education for both parties.
So do you think it's just a question about funding then?
You know, it sounds almost vulgar, but funding is huge. If we don't have the money to get to train the staff that we need, if we don't have the money to educate all parties, then we are just going to remain ignorant as to what we can do to improve the quality of life and healthcare of everybody.
So what kind of digital innovations would you like to see? Because there are lots of startups here in the audience. So go ahead, challenge them.
Gosh, well, how are you going to how is your innovation going to be cool enough that patients are going to be interested? And how are you going to translate what you want to achieve so that patients and families can actually understand it and value it?
So just thinking about digital innovations, do you use anything at the moment that has, transformed the way you live?
Yes, and I wish this hadn't come down to COVID and lockdown, but being able to do so much more online is so helpful. It means that I can access my data much more quickly. I don't have to phone and speak to a million people in reception until I get through to the right person, which is so stressful and can cause a seizure. Instead, I can just access this information quickly, which is great for my mental health, my neurological health, and for health as a whole and quality of life. And I think you'll find that that is the case for so many people, no matter the disease that they might have.
And what about real-time monitoring? Could there be something like that where they could measure something, and perhaps I don't know enough about epilepsy, but could they predict that you're going to have a seizure or be worse?
We have lots of projects going on at the moment, kind of silos, I would say, different groups of people within organizations and startups who are trying to be able to help us to predict when we're going to have a seizure. We've got a long way to go, especially considering there are over 60 types of seizure and, so many variations in each individual patient. We're going to get there, but we need more funding in order to achieve that and for organizations to work together in order to do that.
So I'll come on to talk about data with you a bit more in a bit, and especially about the reluctance of many people to share their data. But I just wanted to come to the broader question about epilepsy, because we think of the dramatic effects and the symptoms, or, the seizures, but actually it's much more, shall we say, insidious than that.
Yeah, I've been called complex by a person close to me a number of times, and I think that perfectly describes a disease such as epilepsy. As you say, it's not solely about the various different types of seizures that you might have. In fact, I personally, as with many patients, rather have a seizure every day of my life if it meant that I was much more stable psychologically. Because what is the point, for instance, in having controlled seizures if the rest of your life you don't feel is worth living? There are multiple comorbidities in addition to the psychiatric ones. Lots of people have problems with digestion, with mobility. It's very, very common to have cerebral palsy, autism, intellectual disability, and multiple other conditions alongside it. And those other conditions can be more important to the individual and family than the epilepsy itself. And what's also worth mentioning is that if you improve a patient's quality of life as a whole, then you're the other disabilities or diseases I mentioned, then you are actually indirectly, very often, going to improve the epilepsy and reduce a person's seizure frequency.
So does epilepsy then go undiagnosed because it is so broad, and you're talking about all these other, intellectual disability, depression? It could come under all sorts of different diseases or problems.
It's really common for people actually to take years to get diagnosed. I'm showing my age, but back in the 80s, it did take years until I was diagnosed, because the type of seizure I was having, a focal seizure, nobody noticed. And that happens even today. It's 2022. This happens a lot. So diagnosis and accurate diagnosis is so very important. There's an amazing neurologist called Sandor Benitsky, and he did a presentation explaining how 30% of people who were diagnosed with epilepsy didn't have epilepsy. So it can go the other way. Instead, they had non-epileptic seizures, or psychogenic non-epileptic seizures, which is a psychiatric condition. So we have to be accurate in diagnosis.
So I just wanted to, if there are any startups watching at the moment, do put your ideas in the Q&A. We'd love to see them. So let's go to the data side now. And you talked about unwillingness to share data, and we talked about this yesterday. So what do you think needs to be done to educate patients? Because it's not just patients who have particular diseases. Any patient who goes to the GP now has to probably sign something that says they don't mind if their data is used somewhere else.
It sounds harsh, but people need to realize that as an individual, generally, when we're looking at big data, theirs isn't overly important. It's about the combination of data from lots of different people. I think lots of patients are very, very paranoid, and families about sharing their data. And a huge reason for that is that they don't understand how the data is culminated and how it's used. We need, again, it's back to education. We need to be able to explain to people, this is how the data is used. Yes, it will be used for you individually as well, but it's just, I don't know how to say this politely, which is quite a struggle for me, but it just often isn't as bad as people think. And always, let's remember that when we're sent an email, for instance, we can go to the bottom and say, don't contact me. And it is exactly the same for data sharing.
So that's interesting, because you're talking about big data there. But what about, when you're coming to personalized medicine, you're going to perhaps have to share a bit more personal data?
If people expect to get the best quality care possible, then generally speaking, they need to be able to share as much data as possible. Often people don't understand that. They assume that a clinician or an organization or pharma, bad pharma, is going to steal that and use it for something else. We need to reassure them and show evidence that that is not going to happen and that it is for their benefit to share this data.
Thank you, Tori, for being such a passionate advocate for epilepsy patients. Round of applause for Tori.
Thank you so much.
Thank you. Right, now we're on to our first plenary of the day, and we're going to be talking about the rise of telehealth. A few years ago, telehealth was in many countries an aspiration, with a few pilot projects here and there. But within months of the pandemic starting, telehealth for many became the only way of accessing or delivering healthcare. But now that it's a reality, what else is needed to make sure that telehealth is fit for the future? So to share their expertise, please welcome Terje Peitso, Member of Board at North Estonia Medical Centre, who's going to be leading the discussion, and also Daniel Forslund, Head of Innovation, Swedish Association of Private Care Providers. Hi. And Thorsten Lambertus, Head of Neurotech Labs, Germany Biogen, and Hans Daniels, co-founder and co-CEO of Biteflies. Hello, thank you to you all. So, Terje, welcome to this conversation now. So I'm sure many people know that Estonia is one of the most tech-savvy countries in the world, and the government has made digitalization a key plank of its economic growth. Almost every bureaucratic task can be done online, and in fact, you can even be an e-citizen without having anything to do with Estonia or even living there. So what do you think is let's think cookery now. I don't know why, but let's do that. So what do you think is the recipe for success in rolling out all things digital? And if you could give me the 3 top ingredients.
Thank you. Good morning, Europe. Good morning, Stockholm. What can I say? I would say that you have to grab the opportunity. And what is in this opportunity? You have to know what the needs are, what the possibilities are. You have to, in healthcare in particular, you have to demonstrate the benefits, and you have to find the resource. And initially I thought that you have to find money, and that's true, you have to find money, but you also have to find people, and that comes first. You have to find people who know what it is for, what it is giving to them, what they can give to others, and they will really dedicate their time and energy for it.
The people and the skills then?
Yes.
Absolutely.
Yes,
Well, I'm going to hand over to you now, Thierry. And just to remind the audience, do stop putting your questions in Slido, because I'll be back in a while to post them to you lot. So thank you so much.
Thank you. And before we will go to the discussion, because I'm really happy to have here the distinguished guests with me to share the experience. When yesterday there was a lot of discussion about what needs to be done, then at this session we will tell you what has been done and based on what we could do better. So that's the objective of this session. But before going there, I would really like to ask you a question. Go to Slido, and you are all familiar with it because you have done it yesterday, and give us your views of what telemedicine is, how you see it. Multiple answers are possible. You don't have to select only one, because they are sometimes similar, sometimes controversial. You may see that they are expensive but also useless, but you may also see that they are cost-effective and necessary. So give us your opinion on how do you see the telemedicine, which is quite old innovation, actually. I think that it's older. It's probably the oldest of all these technological tools, as old as telephone is. So now, well, I thought that we will get to the point where we have to demonstrate opposite. But I'm very happy that those who voted yesterday, how they would describe the innovation in health as ABBA song and voted for I Have a Dream, either are not here today or have changed their mind, because it looks like super troopers are leading now. So cost-effective and necessary, which is good. So our session is here to demonstrate you that you are right. As an introduction, I would really briefly like to tell you, share with you my thoughts about the telemedicine and what is that we do in the North Estonian Medical Center in that sense. Few principles. Data travels, not patient. I think everybody understands that. The telemedicine means that the doctor and the patient are not in the same place. Telemedicine also is the tool that supports doctors talking to other doctors. So in any case, they are not in the same room and the same place. Very important, and that has been throughout this conference here, is to assess the needs. First of all, you have to have the need, you have to have a problem, and then you can find the solution for it. Not in a way that it sometimes happens that a solution comes to you and then you start to find where the problem is. And what was not mentioned yesterday, but what I would like to highlight here, is the importance of digital health literacy. And you can take it separate, digital literacy and health literacy. But then when you put it together into digital health literacy, you get a kind of new quality. And I think, considering all this information about health, which is digitally available nowadays, this is an important knowledge. It is important education that we have to give. And in terms of meaning of a literacy, it's not only that we know what it is and all this information, how to use it, but we also actually apply it. So that is the digital health literacy, which would bring us then to the better outcomes. On this slide, I wanted to demonstrate you, if we put all this information together, of all sources of health information that is available to us nowadays, then that would be the picture, at least. That is the picture in Estonia, and these are the sources of health information that we are using. And we would, of course, like to use them at the best. Unfortunately, It doesn't yet work like this, but we're working towards it. And we are working towards it by implementing the knowledge that we have gained. And just a few examples that I would like to share with you. I will not touch all of them, because otherwise we would take all the hour that we have for this panel, but few examples. E-consultation is very popular in Estonia, and it is gaining popularity because that gives an opportunity for general practitioners to consult a specialist without sending a patient necessarily to see a specialist. It is online, it is quite effective, it is easy, it requires, of course, preparation, because if you ask a question, you have to give a good explanation. But it also is supported with an access to the picture bank, where all the X-rays, cardiograms, skin lesion photos are available. It gives access to digital health record that the patient has in general from all different healthcare providers, the information all in one place. And it gives an opportunity, basically 3 different opportunities for a specialist, either to take the patient over, make an appointment immediately, if it is an urgent case, give a suggestion for GP for how to continue treatment, or which other investigations to run, or it also gives an opportunity to just approve the treatment, what has been done so far. So these 3 options are what they are given, and so far it, as I said, that the e-consultation number is only growing. Also, what I would like to highlight is the e-ambulance, where in our ambulances, they are all equipped with the Corpus tool, which is connected with our emergency department, where whenever an ambulance goes to see the patient and connects to the Corpus, the cardiogram and all vital signs will be immediately transferred to our emergency department, to the doctor, who will give an advice on how to proceed. In particular, it's useful in our small islands, where we do not have the healthcare professionals in place, but we have the trained medical aid teams who will then, in connection with our emergency department, can take the right decision about what to do with the patient next. Maybe you need a helicopter, because in Estonia we have 2,222 islands. Well, we don't have all of them, this medical aid, but in 4. And that has been demonstrated very effective and gives confidence also to people living in these islands. And finally, the online support for patients, the tools that we have just started with the help of our health insurance fund, the stroke patient with the online contact with the healthcare professionals in the hospital, with the nurse or the doctor, and the other one that we just started now in April is for the oncology patients who receive the chemotherapy and who can submit their questions or describe their symptoms online in a special platform, where they can also use a little bit of artificial intelligence support, the decision support aimed for the patients, or they will be directed immediately to see the nurse or doctor to take it over to help them. And all this information also will be stored in the electronic health record. So I would say that all these examples will demonstrate that you do not necessarily have to have the patient and the doctor in the same place in order to help. You can work quite effectively from the distance. Next year, I'm happy to give you the results of these last 2 projects. But now, I would really be happy to ask my panelists who are working effectively on area of implementing telemedicine. I would like to start, Daniel, from you, because you are working with the primary care providers. You are head of innovation in the association. Mm-hmm. Tell us, what have you achieved?
Well, it's been a very long development in digital healthcare in Sweden. And for context, we were early adopters both for using telemedicine internally in healthcare already in the 1990s. But that was from doctor to doctor, so to say, between the care providers. But we were also early in launching new services for the patients. There was a private care provider launching a service, app-based online consultation service in 2015. Really disrupting how patients saw that they can access healthcare in a new way. Now that care provider is actually the largest one in Europe because they are establishing themselves across the EU. And they have also triggered a development where all the both private and public care providers in Sweden are actually involving themselves much more in the digital transformation. And online consultation is now stands for around 15 to 20% of all the consultations in Swedish healthcare, and that's a very large increase during the pandemic, of course. In my previous role, I was working in the region of Stockholm. We had a sorry, my voice is a bit losing my voice here, speaking too much with all of you excellent colleagues. Well, before the pandemic, we had around 2% of all consultations done digitally. But now, during the pandemic, it was 25%, and now it's between 15 and 20% across Sweden. And we also have 4 major digital online care providers that has really been forcing everyone in the traditional healthcare to also go online in an early stage. And we are now really trying to integrate the digital and physical world in healthcare. And we don't use the word telehealth anymore. We actually have invented a new word in Swedish called digifysisk, both digital and physical healthcare, because healthcare shouldn't be either one. It shouldn't be only physical or only digital. It should be also always a variety of both and a combination of both. So we try to now launch this in all the aspects of healthcare, not only in primary care, but also in specialized care and in our hospitals. And that was the biggest transformation during the pandemic, that we can, here in Stockholm, in only 4 weeks, we could open our online consultation for all our emergency hospitals, 5 of them, in only 4 weeks. That would take 4 years if it hadn't been for the pandemic. But now we really had to rechange healthcare in a very profound way. And we also entered this online consultation for areas where we perhaps didn't think that it was possible to have online consultations. For example, in psychiatry, we could see that our experiences from earlier on cognitive behavioral therapy online could now be expanded to consultations live with your therapist or your psychiatrist, and that was increased by, I think, 7,000% during the last few months of the pandemic, and that has stabilized that psychiatry can now reach persons who have anxiety and who wasn't willing to visit a psychiatric clinic because there was a bit of shame and uncomfort traveling to that clinic. Now you can meet your psychiatrist in the comfort of your own home, for example. We also treated patients with obesity online, how to help them with nutrition and support in their daily life with connected how to weigh yourself scales and also for measuring your blood pressure and other things. The obesity care was actually 100% digital during the pandemic because they were a risk group, and that has been stabilized so that those patients, they only want to have that kind of treatment online nowadays. We also, one of our care providers in Sweden moved to a digital service for even people with sleep apnea, if you have sleep disorders. We had very long waiting times because it was a complex investigation on how to get that kind of treatment. And the waiting time was 1.5 years in the region of Stockholm, and that was not, very good. But by using these new tools and new sensors and a kit where you can really try to use this and measure yourself during your sleep, we cut the waiting times for a treatment from 1.5 years to 2 weeks. And we can also have online chat support for those patients in an entirely new way, which is really appreciated by both health professionals and patients.
Daniel, tell me, is there a patient who is now going to the office actually?
Yes, there is, of course, because healthcare should always be a combination of both physical and digital tools. And sometimes the discussion could look like that, well, now we should, only use the digital tools and healthcare is no longer a physical place you even visit. But of course, you should visit for examination or for a treatment, but sometimes you don't actually have to do that because healthcare should be a service following you in your mobile device wherever you are. And that is actually tearing down the walls around healthcare. It shouldn't be only the hospital or the health clinic. Those competences should be available to us wherever we are, and also to have an individualized way of meeting healthcare. The physical contact is not for everyone. Perhaps you have a long way of traveling, you have anxieties, you have a risk of catching a disease, so you should actually be treated in your home or in your, supported in your daily life if you have a chronic disease, for example.
No, I absolutely agree. I would say that in Estonia, the most popular televisit is with the psychiatrist. And it's a pity that we have nobody from the Netherlands here, because in the Netherlands it has been already for many years the prerequisite for having a contract with the insurance that you have to provide the telepsychiatry service.
Yes.
So I think that we have learned from them and catching up. So you have so many different options. Yes. And we have Hans and Torsten from the industry side. I can't call you SMEs because you don't look like SMEs anymore. But you are providing these tools. Hans, let's start with you. Give us a good example of what is that you have achieved in this context.
Yeah, thank you. And well, I would call ourselves SME. We're still a startup, scale-up. Maybe to give a little bit of context there, we are with Biteflies focusing on telemonitoring. So we already exist for 7 years. For us, COVID, I think for a lot of people, COVID was a pivotal moment, but for us that was definitely the case as well. Because pre-COVID, we were developing tools and offering them to researchers, pharma companies to use them in trials. And our goal was always to get it into care, but we had the approach of it's going to take quite a bit of time because the healthcare system needs to change, payment needs to change. And then COVID happened, where all of a sudden there was this huge crisis, there was this huge burden on hospitals. And that for us was a moment of, let's say, we do it now or we never do it. And so we made a drastic pivot. We said this is the moment where we want to offer our remote monitoring solutions to patients. And very practically, we formed a consortium. We built a solution called COVID Care at Home. Basically what it does is it takes people that are hospitalized and gives a tool for specialists to be able to follow them up, but not in the hospital, but at their home environment, to free up beds. To give you an idea, a hospitalization day costs around 1,000 euros. A week of follow-up costs around 50 to 100 euros. So in a matter of 9 months, we went from ID to solution to first patient in to 50% of the hospitals. We actually got in touch with the government. We negotiated reimbursement for telemonitoring for COVID. And we basically saved several thousands of hospitalization days during the peaks. And this is a solution that was mainly used during peaks where hospitals were flooded. For us, this was very important to show that the impact of these solutions. Because pre-COVID, a lot of these activities were on pilots, and let's try it, and then let's have a discussion how it works. For us, this was really a moment where we said, okay, we want to have impact. very acutely now on this acute crisis, but we want to show bottom up, not with a pilot, but in the actual use cases in the hospitals by working together, that it works, that it's a saving, that it doesn't need to have a burden on the specialist. It gives value to patients, it gives value to everyone. And that's what we see happening now as well, because there was this moment during COVID where we deployed that, but while doctors were using it during COVID for COVID patients, they started also asking questions. Can we use this for flu patients, for COPD patients, for other emergency care patients? And they started testing it for these patients as well. And now we're rolling it out to have it for these other patients. And we are also offering another solution, cardio care, which is a little bit more specialized, but to follow patients at home who had a stroke. So patients that had a stroke need 1/3 of patients could have an underlying heart condition. So they need to have a week or a couple of weeks of heart monitoring. Very often that happens in the hospital. They're just laying there being hooked up to a big monitor. That's very expensive. They actually want to be at home, but you need the monitoring system. And with our solution, but there's other solutions as well, this transformation is happening, and it's happening much faster. Every week we see hospitals that start using it. We see we have a response rate of more than 50%. We have more than 50% of hospitals that go from first meeting to really testing it to start using it. So really the adoption of these specialists and these hospitals that pre-COVID were more talking about how will this help? Is this something we need to do, etc. Now this is really shifting to action. This is out of our experience, but I think, Daniel, you gave a lot of examples as well. There's lots of other companies, even in this room, that are experiencing the same things. And to be honest, despite the horrible things of COVID, that's, to be honest, a very positive takeaway from me is that I think it was the needed spark to really ignite the whole transformation, because otherwise, I think it would have still taken a long time while it's happening now.
That was a need, obviously.
There was a huge need.
Yeah. We have been speaking about mental health, and I would say that, Torsten, you are representing the neurotech. How have you entered this healthcare system now?
So first of all, I would like to mirror two things that Daniel and Hunt just said. I think hopefully in a couple of years from now, we don't need dedicated sessions on telehealth anymore, because it's seamlessly integrated into the healthcare system. And someone like me, I'm part of this sector and industry now for a year or so, have been working in innovation in many different industries. I have seen this transition, right? And in the very beginning, it's hard for people in the system to adopt these digital tools. And sometimes things like COVID happen and people have to do it. And then they see maybe the beauty of it and how it can actually help. So we are lagging a bit behind here. But I think and I hope that for the sake of helping patients better and the doctors in the entire system, the adoption rate will even increase. And just to also mirror the point with COVID came, we were supporting in Germany a tool that helped the doctor to connect through calls with the patients because, well, we had a hard time to meet each other during those 2 years. And the point is, it was sold like it's now a necessity because there's no other way to meet. But we should see more the opportunity of what this means also for future use cases, how this can enable a better care. And I think this is something that should be promoted even more. So for Biogen in general, in the neurotech space, we are betting a lot in general on digitalization. We set up an entire unit which is called Biogen Digital Health, which is comprised of people globally with different backgrounds, digital skills. This is exactly the literacy that we also need for our people working at Biogen to understand that world. And we are building an entire portfolio of solutions, starting with something like patient services, an app for our multiple sclerosis patients, Clio, that helps them to understand their disease better. Then we just launched Neuroflix, so you see it's quite similar to Netflix, which helps doctors to share knowledge with each other, which is also, I think, a great example of how we can leverage the digital world. And there's top-notch tools like Connectome that help us to do patient monitoring, to understand outcomes better during therapies for MS. And this is just the starting point, and there's more. We just ran the Neurotech Prize together with EIT Health, and we got a global global overview of startups in that field, especially for the Notech Prize looking at Alzheimer's. And if you see how the patient journey changes when you can enter and get access to those digital tools. And I think you made a very good point at the very beginning. We need to also think about the data flow, right? How when people are starting to use apps to do their cognitive tests and they have some interesting data points, how to share that with the doctors, how do the doctors share with each other, the GP, the specialist, all the data and the insights to have a very fast and convenient diagnostic pathway, because that's needed for many diseases, not only in neurology.
Look, I am talking about this innovation in healthcare and the digitization, or let's put it innovation because it's all innovation. Usually we are looking for 3 objectives to achieve. It is expected that with innovation you will save time, you will also save the resource, I mean money, but not only, and you will achieve the better outcome. Of course, it would be ideal if you would achieve all 3, but what can you, from your experience, say? Have you achieved all 3, or focus is on one of them? Certainly, I can say telemedicine is saving time because the traveling time is cut out. But what about the experience in general? Maybe back to you, Daniel.
Well, I think finally we started to measure the time and the quality both for healthcare internally and for patients and for society. Because if you don't only look at what's convenient for healthcare, well, it's very convenient that the patient come to us in healthcare, but still, is that convenient for patients? So we have really tried to put a measure on also the saved time for society and for patients and individuals and for close ones to that patient, because that can really be a big gain for society. And looking at the Swedish discussion, first this disruptive change was very debated because it was feared that this will take resources from the ordinary traditional healthcare if you have too much online consultation. But still, now it's integrated in the traditional healthcare as well. I think the digital is going normal, it's going traditional, and then you can see the benefits, because those clinics who now bought into that digital transformation, they save time both for patients and for doctors, because doctors can meet more patients, they feel less stressful, they can provide better care and more accurate care because they have more time for treatment and less time for all the things around the meeting, because you can have one longer meeting physically and then you can have several online consultations through a chat or for video, for example, where you can have more focused and short discussions, for example. So I think it's a gain for all the aspects here when you look at the overall perspectives, yes.
Torsten, what is your view? What are the gains?
I think we are still in learning mode, and this is okay. And it's great to have all the experiments and also to have startups like you to work on that, and then we will ultimately see the outcome. Of course, saving time is the one which is most obvious, right? And we're working with KMEs, especially in Germany, to see how they are actually translating all the tools that are out there in their daily lives. But of course, for the doctor, it's how can I help my patients better? I have limited resources, I have limited time, and if those tools help me to do my job better, I'm super happy of applying them. At the same time, we all know there's quite some hurdles, interoperability, then the question how is it easy to use, all the tools that we have right here. I know when I started my job at Biogen, one of the first things I did, talk to my new stakeholders and target groups, which is primarily also doctors. And so I just asking the question, so what is your experience with digital tools? And the guy was complaining for 10 minutes that all the tools he's using, there's so many apps, how to integrate them, then it costs him more time than before to do the same job. So of course this is creating a bad experience. And this is also what happens, that doctor is saying, well, don't tell me anything about digital. I'm fed up with this, and this is of course not the picture that we all together want to paint, but that's part of the learning journey, right? Whenever innovation hits a system, there's friction in the very beginning, and over time this will be resolved, and this is exactly the phase we're in. So what exactly are the outcomes? Who is going to benefit from what? To be seen, but it's good that we are experimenting and that we are creating this friction.
Hans, how is it in Belgium?
I think in general, I think the primary goal should always be outcomes. I think that's the main target, the impact on patients, better outcomes. I think the beauty is that it's a win-win-win. All three things can benefit, price, time, and outcomes. And then to give a very practical example, not only in Belgium, but worldwide, is actually building up on the story that Tori has told us before in the previous session, is we also work on epilepsy, and we see it there on every day, there's lots of people living with epilepsy. There's a huge burden. 1/3 of patients are not on a stable medication. It takes a very long time. It's a very difficult journey. There's a huge impact of life for a lot of these patients, and it's very personalized. And the problem there is like you say, that on one hand, it's not a problem. There might be a little bit of a problem of better drugs, but the last 20 years, there have been 15 billion of investment in new drugs. There has been no change in impact. The problem is the tools that specialists are using now are not adequate. They have basically two choices. Bring someone in for a day of video monitoring, costs a couple of thousands of euros. It's very uncomfortable, it's very expensive, and very cynically, if the person doesn't have a seizure at that moment, there's no information. They send them home, say, use this medication, come back in 6 months and write down in your piece of paper, on a piece of paper, how many seizures you had. While there's lots of different seizure types that people don't even know when they have them. So we need to give them new tools, like with EpiCare at home, but there's other companies now there as well. We are giving these tools to neurologists. We see that in more than 70% of the cases, so that it's a tool where they can send the patient home, say, you take this drug, we're going to monitor for you for 2-3 weeks and see how many seizures you had, and then see to which extent the medication works, whether we need to adjust the dosage, whether we need to switch to new medication. And we see today, while neurologists are using it, that in more than 70% of cases, it's still anecdotal, so we're learning as we speak, so don't quote me on the number, but it's anecdotal evidence that in more than 70% of those cases, they could make a decision that they couldn't make with the current tools that they have. They saw that medication is not working, the dosage was not right, they confirmed that someone was actually seizure-free and they could get a better insurance, or they could get their driver license back, and all these different things that have a huge impact on the patient. But also impact on the trajectory to get to the right treatment. And the right treatment for you today might be different than the right treatment for you in 2 years, or in 5 years, or in 10 years. And also from a cost point of view, someone with epilepsy, like the hospitalization day costs a lot. There's indirect costs. It's a huge cost related, direct and indirect costs with the current system, which will go down with having these tools.
You wanted to add something to this point?
Yes, but I think we often talk about the cost-benefit analysis for society or healthcare organizations, but we also should really put a measure on the quality of life for patients, because technology can really be the tool for freedom to live your life, even with your chronic disease. Because, well, these online consultation models were, the early stage, it was only for very, well, simple treatments, so to say, as in primary care or your first contact, then you had to visit your doctor anyway. Now it's really that you can provide continuity and freedom for patients with a chronic disease or fairly big and ongoing disease. And you don't have to visit your health clinic at your hospital 3 times a week or twice a day, or what could be the case sometimes. Now you can live your life, you can go to work, you can do your measurements at home, you can send your data to your hospital. And yes, there are huge obstacles when it comes to the lack of interoperability and compatibility, but we have to solve them, because patients are really driving this change forward, I think.
Well, that's actually good that you said that the patients are on the driving seat, and I absolutely agree. But the changes do not always come in a way that the patients will highlight the problem and then the system will start changing based on that. How in modern life nowadays this change should happen? Who should be the initiator? Or maybe they all should be. I am thinking about the policymakers, I'm thinking about the technology guys, I am thinking about the healthcare providers, the hospitals, as me. Where should it come from? Or should it come from all, and how then we share it? Because I just give you an example. In Estonia, there was recently the survey among the citizens, which demonstrated that 62% of people would like to have the video consultation. The doctors are not so eager, so to do it because they would still like to see the patient and to touch the patient and to be sure that what they see is true. So I'm just wondering, if it would be you, who would you put in the driving seat? I think that Hans and Torsten, you are in the driving seat because what you said, there was very much an initiation of this process. Where did the idea come from?
I think so. I think we're all in the driving seat. I think this is not a one company or one stakeholder game. Everybody is involved. To be honest, I personally think is that both patients and specialists and hospitals, they are in the main driving seat. We play a very important role, like from a startup company, maybe big tech companies, policymakers, etc. Everybody plays a role. But if we talk about outcomes, how can we help a patient? How can we help the outcome of a patient? Both a patient and a specialist, they have the best view on the patient trajectory. So they play a very important role. I think where I speak personally from a startup, scale up, and smaller companies. Our role where we can help is by doing it. We like action, and I think a lot of these things, and that's what we really try to do with COVID as well, is go from talking to doing. Because a lot of these questions, they come from not knowing. They come from doubts like, how does it integrate? How will it integrate into my operational flow? When we started launching COVID care at home, we went to hospitals, and every specialist was saying, this is interesting, but I'm afraid it will take me a lot of time. I don't want to spend more than a minute on it. How will it integrate into electronic health records? We can have hours, days of discussions. Our role, or how we try to tackle it, and I think the way forward is by actually showing it. This is how we do it. Does it help you? Not good enough. We'll change it. We'll adjust. We keep on doing it. We keep on iterating it. We can move fast. We went in tech from the first iPhone to the iPhone we have now in less than 10 years. It's not about we need to engineer the whole system in our minds and then implement it. We need to start, we need to do it, we need to show how it works and keep on improving. And that's where I see our role. And you can say in the driving on the driving wheel where it is from an action point of view, but I see ourselves more as facilitators. Is really helping bottom up to show this is how it works. Do you agree or do we adjust? Because what we experienced also before COVID is by asking, what do you need? What is the tool you need? Also, for example, for epilepsy, we talked to a lot of neurologists and asked, what is the tool you would need? You come with very theoretical things like, a wearable that people can wear for 10 years in a row that is perfectly accurate and has no false positives. Okay, let's spend 20 years now developing it and we'll probably never get there. While if you start with a tool that already does quite a bit of things, it's not perfect, but then all of a sudden they start using it and say, wow, cool, this can really help me today. And it's going to improve. We're going to go to this accuracy and long wearability and prevention, etc., or prediction. But we have to start now. So our role is in the action. Policymakers, they need to help to create an environment where it's easier to iterate and don't create roadblocks. But the patients and the doctors, we need to help them voice what they need.
Yeah, and I think that this environment also needs to be adjustable, because otherwise you first create an environment and then you don't fit into it.
Exactly.
So,
exactly.
But what I wanted to, let's first hear, Torsten, about your experience. Who is your driving seat? Because what I said myself that you have to identify the need, and that's true, but there is another aspect in it as well, because not always people don't know what they need, but they can describe the problem. And then based on that, you can design the solution. Because otherwise, we end up with this famous, often repeated sentence that the car manufacturer Ford said, that if you ask people what they want, they say that they want a fast horse, because they don't know about the car. So, Torsten, what about your view?
But that's a well-defined problem beyond healthcare, right? How to innovate the right way, and understanding your customer and the pain points out there is critical. And I think we came to the decision at Biogen that even more important than what we are going to innovate in the future in that space, even more important is how we innovate. And think just sitting in our ivory tower and thinking about the healthcare system of the future from our perspectives is not going to help anyone. But going out there and finding the pioneers, finding people who are ready to experiment, finding the right sandbox where you can actually run this experiment, and then go into action and iterate based on the solutions, get the outcomes and the feedback from the people who need to be involved, the patients, the doctors, and all the other relevant stakeholders is exactly key. And this is what we need to do. But hey, that's for a pharma company, that's a change of mindset, right? We are still in learning phase how to do that. But I think, again, it's about starting the journey, and then we'll learn along the way. So I don't think it's just us or the payers or whoever should be responsible. It's getting together those who want, and then do it.
Is the same in Sweden, the teamwork?
I think so, because it's the partnership between healthcare and tech providers that can really solve this, I think. And also looking at, well, if it's the patients and the tech companies perhaps driving this change, well, who's in the backseat? Well, sorry to say, it's us, the policymakers, because I've been a policymaker for 20 years in Swedish healthcare, trying to be the change maker and trying to open up that kind of innovative culture where you can really change things and, well, open up ourselves to the new ideas from medtech companies, tech entrepreneurs, and also from patients and professionals, naturally. But still, healthcare is built for another normality where the digital tools are abnormal. They are not built in our system. Healthcare is that building, that place you go to, and reimbursement systems is only supporting that kind of interaction in a room where you meet your doctor in the same time in a room like we do now. If you're online on a screen, it's very much harder to design that kind of reimbursement or that, description of what is a care visit. And I think the tech industry must be the disruptors, and patients will use the best technologies available. They don't see the obstacles that we can see internally in healthcare, that, things is not interoperable, things is not working perfectly with data storage and so on. They just want the best care when they need it in some way. And that's a very strong driving force. Why we were very fast in adopting online consultations in Sweden 7 years ago was that, it was a loophole in the national legislation making it possible for you, choosing the technology you wanted to visit your doctor. That wasn't even imagined when they wrote the law 10, 15 years ago, but still it happened. And patients used that, and the tech entrepreneur found a way to offer that kind of service. Now it's a commodity that everyone wants and everyone uses, and we try to re-regulate healthcare. But still, regulators, policymakers is, sorry to say, in the backseat. We are not setting out the goals as we should do, I think.
Yeah, well, sometimes. Just to remind you that we have this slide opportunity to ask the questions, and we will come to you in 5 minutes, actually, to answer the questions that you have. So don't forget that opportunity. But before doing so, I would like to have my question to you about obstacles. Torsten, what is your major obstacle you have to overcome right now? And maybe the audience can help you.
Well, I think the biggest hurdle so far is a mindset hurdle, right? And I think I described it very well inside my company, inside the healthcare system. People are very reluctant to experiment with stuff, right? And I think that's something that will change over time. But whenever people, and I'm talking to a lot of doctors, I'm talking to quite some patients always, if possible. And whoever is starting on this journey, maybe they find flaws. And maybe they see it's not yet perfect, but they are the right ones to come up also with the solutions. And I think we need just to find the people who are willing to get on this journey, and finding them is sometimes a tough nut to crack. And so I'm always searching for the ones who are ready to work with us on new projects and try to get all the new tools into practice. Because also, there's a lot of tech entrepreneurs and there's a lot of people who gain the experience in building digital tools in other sectors, and now they're coming to healthcare, but they need to learn a lot too, as I'm still learning every day in this industry. And I think, again, also for them, it's important from a mindset perspective, hey, we're not the disruptors because we have built a successful e-commerce company before, and it went public and we IPO'd. Well, that's great, but now you're a different system and it works differently and it has its special rules. So learning from that side is also quite important. And sometimes I see startups who don't have that mindset of, hey, I need to understand also the legacy of this system and how it works and how I can apply my knowledge and my tools into that very system.
Hans, your obstacle.
I like to call it challenge, and obstacle sounds too negative, but I think one nail that I want to hit on is I think, which is crucial to bring this forward. There's a couple of things which we will fix along the way, but one very important thing is payment, reimbursement. How will these things get paid by, the change from payments that are, depending on which countries, from fee-for-service towards more payment systems where this whole telemonitoring is encapsulated. There's lots of things happening. I think there's lots of trends in the good direction. I speak from a company point of view. I think it's essential to thrive this ecosystem. And that's where I also look at policymakers. I don't ask for a solution right away, and that's not needed. I ask for very clear statements: is yes, we're doing this. This is the future. We're gonna go to a system where this funding of healthcare is gonna switch to physical plus telemonitoring. We're doing this today because this is important for different stakeholders, change management, a lot of people that are afraid to lose money. I don't think that a lot of people will lose money. I think it's about making the system more efficient. So to help comfort them. It also helps, what is very important is people investing into the sector, also in companies like us. We need to bring it to scale. If I talk to investors, if companies investing in this, they need to see like, okay, this is not solved today, but it's not a blocker. This is everybody that is at the knobs that are decision makers as well, not only today but in the future. They have the vision that we go there, and they make a very strong statement towards everybody. We're going there. This is going to happen. It might take a little bit of time, but it's going to happen. There's no question about that.
Daniel, do you have the challenging obstacle?
Well, there's a lot of them actually, and many was mentioned, the culture, the reimbursement systems, but I think it all boils down to the lack of leadership sometimes. So to really have both clinical and political leadership in this sector to set out the goals that we need to change. We need to rebuild our reimbursement systems. We need to rebuild our agreements between the payer and the provider in this field. We need to open up ourselves to the innovators and the entrepreneurs who can test their new solutions in healthcare. And that requires leadership, both from the clinical and political side, to make it not so discomforting or even scary to embrace these technologies. I think that's the key thing. Yeah.
Well, if I may add here, I have 5 seconds to finalize. From my point of view, one of these challenges is how to learn from others, how to find out what others are doing and take it from there, not to necessarily reinvent everything ourselves. Because there is a lot of good experience available in Europe and worldwide, and this type of knowledge sometimes is difficult to find, sometimes it's too easy to find, and how to then find the proof. Because that's what I said in the beginning, you have to demonstrate the benefits in order to convince your partners. That is something that we are really looking for, and I very much hope that the conferences of this type of format or publications, they would really share the good experience that people could learn from. So have people turned to us with the questions?
Yes, they have. We already have 3 questions, and thank you. Really interesting conversation. It really felt like a conversation, so thank you for that. So Hamish has actually sent a question saying, what strategies can be deployed to overcome inertia for telehealth and other digital technologies in healthcare? So who'd like to take that one first? What strategies could be taken to overcome inertia or apathy?
If I start, we tried a solution in Stockholm here in this region, to really foster a new culture of innovation that you could try the new solutions. And we connected a network of innovation offices in our hospitals and in primary care. They could seek special funding from an internal innovation fund, and we also mandated the hospital leadership that they need to open themselves up to these ideas. Innovation is a part of your daily life, and that was actually a change process that was very fruitful for the Stockholm healthcare system. To have hands-on support. If you have an idea, I want to work with a new technology, I want to work in a new way, you can knock on the door in the innovation office and get a project manager to help you out. You can have help seeking funding from internal innovation fund and so on. So that was one way of making it not only strategically right, it's actually you have the support in your daily life as a clinician.
So that's interesting. So both practical, but also change of culture there, because you're talking about the leadership there. Terrier, do you have any thoughts on that?
Well, I absolutely support the change of culture, the understanding of what can be done different and what are these objectives that we will agree on together. I think that the engagement of all these people involved, from patients, relatives, the families, the doctors, nurses, in one set to agree on the patient pathways, in which gaps we could help with the digital solutions, or where the telemedicine could come in. I think we can really rely on patients and the citizens more, because they can take the responsibility and they are eager to contribute. So I think that we are maybe not yet there with that.
Okay, that's quite honest. Right, another question here. Should we develop common guidelines for doctors regarding when patients can be treated remotely and when not? So again, this is potentially one for you, Daniel, and also Terrier.
Well, I think so, actually, because it's always up to the individual clinician to make that choice together with the choice of a patient. But it could be easier to make that choice if there was included in the guidelines that, in this case, it's preferable if you actually have a follow-up meeting online, or if you have more meetings online and when a shorter one physically or whatever. I think that could be included in our clinical guidelines, and then clinicians should feel safe that they can use those tools. Yeah.
I would say that you do not need the guidelines for telemedicine or digital health. You need the guidelines for treating a disease, which includes possibilities of using telemonitoring or teleconsultations. That is all one set. I think it's time to lose this E from health and have it as normal, functional system which is using modern tools. And that is part of these guidelines. There are no separate guidelines. In my view, we don't need separate guidelines. Sometimes you do, in order to instruct how to use this telemonitoring tool, and where to put it, when to look at this, and who is looking at this. And for the patient in particular, because that is where this digital literacy comes.
Yes. But sometimes it's excluded, not included in the guidelines. So it's really written that you have to meet your patient in this old traditional way.
Yeah, you have to just rewrite them.
Yes, we do that. Thank you.
Do you find that patients are wanting to come back to physical, face-to-face consultations?
Sometimes they do.
Yeah.
But sometimes they like the fact that they can do it remotely.
It's very convenient.
Yeah.
Yeah.
And I think they also feel that in some occasions they really want to meet their doctor, but in perhaps 80 or 70% they want to meet online instead, because they saw that, okay, this is good for this interaction, but for next interaction, let's call online, let's have a phone call, let's have a chat, let's have a video meeting instead. Yes.
I think also it's very important to give that role to medical doctors, also nursing staff, etc., to have more time actually to talk to patients. That's actually where the beauty of these tools, even if you look at patients now who are in a hospital, like COVID patients, very often they had just 1 minute with a specialist. And in the meantime, there were nursing staff, etc., a lot of people spending a lot of time on taking parameters, writing things down in a computer, etc. So even in a hospital, a lot of these people were spending more time on doing, not having interactions with patients, but having interactions with tools that they don't like. So bringing that burden out away from them actually gives them more time, because a patient wants to talk to a doctor. If I have something wrong, I also want to talk to a doctor, but I want to talk about the interpretation of all these things that are being measured about me, and not that they spend an hour just measuring me.
So, yeah, Hans, actually, there's a question here which is probably for you. So you talked earlier about rolling out your disruption during the COVID and actually going much more digital. So how did you manage to convince the hospitals to adopt the disruptive tech? And what did you actually need to do to get started?
I think from a start it's engaging different stakeholders, and so we put up partnerships where we involved doctors, specialists, etc. You know, the first question was, we think we can help. This is how we think we can help, but let's test it first. And what do you think? And let's try it out. And we went first to a couple of hospitals where we started implementing it, where we actually collected a lot of feedback to be able to integrate into it, to mature the system, to basically make sure that the overhead is not big. But the moment when we had these first hospitals and they started using it, and they actually started advocating about it after a couple of patients, they said, this works fine, this is good. They started talking to their peers. And after a while, you know, we went from first call to first patient in a week. Of course, it's COVID and the burden was so big, but there was a value of, yes, there's too many patients in the hospital. If we can monitor them outside, that helps. There was theoretical value. We worked with stakeholders to make it very practical, to also integrate it into their workflow. And then, to be honest, it started selling it itself. We didn't need to sell it. They talked to each other.
Thank you. Well, we're coming to the end of this conversation. It's been really enlightening. Thank you so much. And as the format with all the other sessions, I'm just going to go round the room and ask each of you to just summarize in about 30 seconds your main takeaway from this. So, Thorsten, I'll start with you.
Maybe two quick takeaways. The first one being we need to find more people who are willing to get on this journey and to experiment. And the second one, that we get rid of the E in e-health. So it's just health and it's seamlessly integrated. These are the two key takeaways from my side.
Nice and succinct. Thank you very much. Over to you, Hans.
So my takeaways are, it's happening now. We do need leadership to do the change management, but the beauty about it is it's a positive story. It's a win-win-win. So the leadership should be easy, because actually, in the end of the day, if we do it right, nobody loses.
Thank you. And Daniel?
Well, I think that from the care providers and the tech providers, we need to shake hands and form that kind of agreement on which standards to use, which some principles to use, so that data is safe, secure, and interoperable between our systems. Because then we can really plug in these new solutions in healthcare and make this transition much faster and safer.
Lovely. And now to you, Terry, for some final thoughts.
Well, I would be really brief. I would say we can do it better, but it works.
Wow, that is really very succinct. An absolute perfect soundbite there for a TV reporter. I'd be going, oh, wow, that's so easy. Thank you. Thank you so much to the panelists. Round of applause, please, for them. And I think it's a really optimistic example there in terms of what can be done with telehealth, or we're not going to call it that anymore, digitalization, health. Forget the E, everyone. Thank you very much. So it's time now for a 20-minute coffee break. And then we've got a next session, which was really enlightening, about life sciences, which of course is the key behind the science behind everything during the COVID pandemic and beyond. So do join us then, and do check out the EIT Health booth. Thank you.